Welcome back, fellow mitochondriacs, for another episode of Cancer is a Mitochondrial Metabolic Disease. I hope you got a chance to see and enjoyed the first third of the interview with Dr. Tomas and was able to get some good insights into how to better employ ketogenic metabolic therapy from a dietary perspective. We're going to continue with this video talking about a little bit more on diet, GKI targets, and tracking some solutions to or strategies to improve GKI. But we're also going to talk about kind of, maybe a perspective of how aggressive with my ketogenic metabolic therapy should I be, depending on where I am on the spectrum of disease, et cetera. And then we're going to dive into metabolic inhibitors, DAwn, Mebendazole, 2DG, other glutamine and glucose inhibitors. And then, we're going to talk about, do some of these metabolic inhibitors even need to be pulsed? And then we're going to then talk about some potential reasons why the clinical trials into ketogenic metabolic therapy are being held back. So, without further ado, please enjoy part two of my discussion with Tomas.
Going back to macros and GKI, do you believe that and I get what I think most people who've read your papers and who follow Seafried and also people who follow this channel realize that the GKI is like golf, right? It's the lower the better, right? And I think that you guys have said, in your papers, generally less than two, but goal of one, or if you can get below one, if you're that person, okay. I just want to, clinically, that is very difficult to achieve for most people. And I think that a lot of people have this all or nothing. Like if my GKI is 2.1, I'm like SOL, right? Like this is bad. Whereas I do think it's probably a continuum. Do you agree with that?
Yeah, absolutely. As I said before, I think ketogenesis is on a continuum. The GKI is also on a continuum. Like glycemia itself, the glucose ketone index is formed by glycemia and ketonemia, right? So glycemia, I would say, should be as low as physiologically possible. This is the term that I use in the BMC paper. But this means different things to different peoples in different circumstances. If you are doing dexamethasone or anti-androgens or anti-estrogens, your insulin signaling might be impaired. Therefore, of course, it's going to be harder to maintain very low glucose levels. I think typically in a long-term fast, a person can sort of gauge what would be sort of the lowest physiological lowest levels of both glucose and the highest ketones that you might see during a 7-day fast, for example. And then you are trying sort of to approximate those levels while still eating, while during feeding. And as I mentioned, this is sort of try to approximate what is going on the cell level or on the tissue level in terms of molecular signaling. So it's hard to say, let's say your glucose is 4 millimolar and your ketones are 2 millimolar, then it's a GKI of 2, right? So if your ketones are a little bit higher in one point of time because you have been exercising or you have been fasting a little bit longer from the previous days, and they are 4 now, so 4 divided by 4 is 1. So that's a great GKI, right? But did it really change the underlying metabolism? Maybe you are a little bit more in a fasted state, in like mimicking fasting on a molecular level. But maybe with a GI of 3, when your liver is still making a lot of ketones, but maybe you are using them faster for whatever reason, or maybe your body is already so efficient with using ketone bodies and fatty acid, fatty acid oxidation for energy, that just your liver just makes a little bit less, and your GI is now 3, but your glucose is super stable. There is no insulin, spikes. Maybe it's equivalent in terms of the molecular makeup inside the cell, but gives you a different GKI number. So I think people, it's very hard because all you have is the number. All you can measure is the glucose and the ketones.
Right.
But I think common sense, it's sort of, you can track it on an Excel sheet or something.
That's what they do.
in the BMC paper, I included one Excel sheet also with
that.
the calculator and everything. So you can track it, and if you see it's always in the low range, with no like big spike to like GKI of 20 or 50, and then back again, you have to readapt again. I think this is more likely to capture this antitumoral sort of metabolic priming, metabolic pressure state than a GKI that is very low one day, then very high the next day or the next week, over a couple of days. Then you're getting back into it. I think that's maybe it represents the reality of patients living and trying these things, which is like you can not always be the most strict, and many times it's out of your control. But I think if you are in the lower range, whatever that range might be for your physiology and whatever you have been able to measure, for example, with long-term fasting, and then when you start eating again, it will be different, but it will not be like GKI of 2 and suddenly it's a GKI of 50. It will be, maybe 3, 4. Then you can use that as a sort of metric to try to approximate as best as possible.
Yeah, that's a very reasonable answer. I think that people get this all or nothing. Like if it's not one, like I'm failing, like the treatment won't work, like it's not going to help me. And I think that's probably unlikely, to be the case. And it's just, I think it's hard for sometimes us to conceptualize that these numbers are changing on a second to second basis, depending on whatever circumstances we're putting the body in, so I think that's a very good answer. I appreciate that. And, I think one of the other things and that I think I also maybe struggle with, and first of all, I didn't get a chance to tell you personally, like I emailed you for the first time after that paper came out last December, and I said, man, this paper is badass. Like I'm so happy this came out. But really, the papers you guys have been putting out, that glutamine paper you put out in November, the clinical framework in December, the one they put out in April, that thing was awesome. The misconception paper, that paper was awesome too. You guys are doing great work up there, and I just want to like tell you that.
Thank you.
Really,
yeah.
really.
I'm working. We discuss these clinical things. Actually, that's not what I'm doing in the lab. I'm focusing on like the difference between the Warburg effect and the Crabtree effect. Still working on that. Hopefully next year, it should be ready, at least some version of it. So we are trying to understand the bioenergetics of the problem, and then sort of build on top of that. I'm trying to sort of bridge the gap with the clinical side, but we are also learning as we go. We are trying to have more feedback from patients and from clinicians, incorporating these therapies in the clinic. I would say most of them are doing it right now as a hybrid approach, and I think that makes most sense at this moment. I am completely confident that there is a combination of dietary intervention and diet-drug sort of combination, focusing only on metabolism, on cancer metabolism, that by definition, only based on mechanism, would be able to eliminate or like suppress the proliferation for sure of any tumor, regardless of origin, regardless of mutations, while keeping sort of some difference of therapeutic index or threshold with the normal cells. I think this exists, and this is the research direction that we are following. This is our primary goal. That's why sometimes I think Dr. Seyfried can be very, very enthusiastic in the way he speaks, because we know this exists, and it's very frustrating for us and even for the whole field that we do not really know what is this magical combination, in quotations magical, what is this combination of chemical compounds and dietary interventions that would be optimal for each cancer, that would get us to this level. So given that, and sometimes this is even unrelated to, we can have the mechanism completely described, but then the clinical tools that are available, let's say, 6-deoxyriboxynoleucine DAWN or 2DG or 3-bromopyruvate, many of these drugs, you can have a perfect mechanism, and then you have a drug that maybe doesn't get into the cell, or maybe has low bioavailability, or doesn't cross the blood-brain barrier as much. So you can know what to do, even though you really can't do it in the clinic yet in the optimal fashion. Maybe we need to design better drugs. Maybe we need to rethink, maybe it's a combination of targets. Maybe, one hexokinase inhibitor is not optimal. Maybe you need a drug that targets different nodes in a glycolytic pathway. So I think the standard of care treatments at this point are still necessary for many people, I would say. Maybe if you are dealing with a glioblastoma, or if you are dealing with advanced metastatic cancer, you can, as I always say, one of the core aspects in the BMC paper, the step number one is always evaluate the diagnosis and have a shared decision making with the medical providers. And you should be an expert in all the phase 3 clinical trials for your own diagnosis, and you should know exactly what to expect from standard of care. And this is, you can know it because it's quite well standardized. That's why it's the standard of care. That's why these guidelines tell the clinician what to do. And if you have a GBM, I am maybe I shouldn't be saying this, but I am like more open to patients with a glioblastoma or with a advanced pancreatic cancer that has spread, to be much more like, not disregard the recommendation of the standard of care, but like incorporate what is valuable and maybe adjust the dose of the chemotherapy, maybe rethink in brain tumors, maybe rethink when is the best time to incorporate radiation therapy. If it's a localized tumor, I think it makes sense. If it's butterfly glioma or something, it makes absolutely no sense to irradiate the brain. So try to sort of build your own best treatment, best standard of care for the type of diagnosis. If you are dealing with a early stage breast tumor, do the ketogenic diet, do it as best as possible, incorporate some fasting, incorporate some supplementation. Maybe you don't have to go out of your way to research about glutamine inhibitors or hyperbaric oxygen, all these other therapies that we would be recommending. So I think standard of care is valuable. It's just, we would say it's not used in the best sort of context. The body is not primed for it to receive the maximum benefit.
Right. I think that really begs two discussions. Number one, I think I'll start with is that there are certain standard of care treatments that are being used that will clearly derail ketogenesis, right? Like, for example, I think the most obvious is glucocorticoids, and they are pretty widely used for most chemotherapies. I'm trying to figure out still why it's almost in every chemotherapy regimen, whether it's, regular chemotherapy or whether it's immunotherapy. And I think that I got some of the answers that I'm looking for, but not all of them. It seems that they're liberally used. And I also don't think it's all or nothing too, right? Like if you have a GBM and you have like vasogenic edema and you're like midline shifting, like that's a different situation than like just throwing in some dexamethasone for this other person who I don't know exactly why they would benefit from that medication, but there are certain medications that obviously will do it. The GnH are, the gonadotropin antagonists, like you mentioned, like the leuprolide or any like Casodex, any kind of like chemical castration we're doing for people with prostate cancer. I have found that it really does affect people's GKI and their ability to get into ketosis pretty substantially. So do you have any practical, like, I don't know, advice clinically how to avoid, I don't know,
Yeah,
that?
well, I think what you mentioned for the dexamethasone, for brain tumor edema, I think that's a justified indication. There
Nothing
is
you
like
do, yeah.
not much to do. Although there is other things, there is COX-2 inhibitors, there is the aldosterone angiotensin system, that there is other medication that could be incorporated to reduce the dose as much as possible, which is not being done in the clinic. Sometimes for the other cases where it's prescribed sort of as a, I think we know that many of these chemotherapies are highly toxic to the normal cells, and they like inflame the whole body completely. So these are sort of adjuvant therapy, supporting therapies to try to make it easier to tolerate the standard treatments. So you have two options. You would either have to adjust the dosages of chemotherapy, or you have to use the dexamethasone or just other corticosteroids that are like prednisone that are less powerful to control some of the inflammation. Despite that, I think in a couple of papers that have been published, and I have seen it myself, you can still get relative glycemic control with reasonable doses of, for example, dexamethasone, up to 4 milligrams per day. I think you can still have ketogenesis. You can get into ketosis. The same for anti-estrogens and anti-anabolic sort of treatments. It's going to be harder and you might need maybe supplementation, maybe throw in some exogenous ketones. Ultimately, you can see it during fasting if you are on these treatments, and even despite 5 to 7 day fasting, you really just can't, which is difficult. You will get in ketosis, I think, if you're fasting for 5 days, whatever the status is. But if you don't feel good during the adaptation, and if the adaptation is impaired and the metabolic flexibility is impaired, I would still stick to the ketogenic diet, low carbohydrate diet, because it would still provide benefits from the insulin signaling. Because if your body is more insulin resistant, I think that's the logical state to be in. You wouldn't combine, glucocorticoids with the high carbohydrate diet.
Right.
But it can be impaired, and I think the whole the cortisol axis of stress management is very important. I don't know what you would say are the most interesting tools. People do adaptogens, people do psychotherapy, people do meditation, people do prayer, many different things, limbic retraining. There's like many different things that people try, and I think they are a core component of what we are talking about, because it impairs everything else. If you are doing all the therapies and the diet is perfect,
Right.
but you are stressing out of your mind, the biology will fight you. It's
Yeah.
just the way we evolve. If you feel you're gonna be dead tomorrow, and you're being chased by the lion,
Right.
just the body is in a state that impairs these adaptations. It will still happen. Like
Right.
if you fast for 7 days, despite the lion, you will still get in ketosis, but your glucose might be higher for sure.
Right.
Gluconeogenesis will be higher.
Yeah. Now, I found that clinically, getting people down to the GKI targets can be very difficult, if not seemingly impossible. And I just didn't know if you guys had anything, I mean, I found a lot of things, both drugs and supplements, that can have an effect. Obviously, there's mind body, like you mentioned, exercise is powerful, no question. There's a lot you can do. Even meal timing, like how you structure the meals, like what you do before and after a meal, can make a big difference in glucose spikes and mitigating that, lowering A1C, come a more of a general way of doing it. But I didn't know if there was anything in particular you guys had found. Like I had one client who I think it was based off of the podcast with Seafree, because he said that he was thinking that basically you may uncover kind of inborn errors of metabolism, or like partial inborn errors of metabolism, that you would never really see otherwise unless you were putting someone to this deep ketosis. So like, and I also noticed in your paper that I reread some of the pieces of it, and you guys had mentioned that maybe there's like a depletion of carnitine. So I had given this person carnitine, and they improved their ketogenic diet. I mean, their ketosis improved kind of radically. So I just didn't know if there was anything like that you've seen kind of over and over again clinically, that like, okay, yeah, you have to add that in like after a month or something like that.
Yeah, I think carnitine, is important for the fatty acid oxidation process. So that makes sense. The electrolytes are also very, very important. Supplementation from, different, like anti-glycolytic agents, like more like insulin modulators, like berberine. Some of these things can also help to just keep it a little bit more stable. I, I don't think, for my thinking, I don't think there is like a secret. I think you should try to cover all the micronutrients, all the things that the body might need to sort of work in an optimal capacity. Sometimes it also takes just time, like
Right.
many, because you have to eat at least once a day, or like once every couple of days at least, and there's no choice. You just have to go through the process of adaptation, slowly or quickly, depending on what the body needs. So yeah, I would say evolution sort of did the hard work of mediating these adaptations. Or the body knows what to do. But of course, if there are other standard of care treatments that might be impairing it a little bit, or other conditions, it might be just a little bit more difficult.
Got it. I think that if it's okay with you, we've talked a lot about the ketogenic diet. I've heard you bring up fasting quite a bit. I had quite a few questions about that, but I may digress and just move on a little bit, if it's okay with you, because I had questions about fasting, types, and even macronutrient quality versus just the strict numbers. But I think that some of the things that I'm really interested in particular, are some of these glucose and glutamine inhibitors, both drug and potentially non-drug, and potentially how you could see them being implemented clinically. And I think this is where it went back to something you had mentioned earlier. You said, okay, maybe if you're DCIS, and you have a lumpectomy, you do some little bit of a ketogenic diet, you do something, but you're not full on going into like high dose dawn and like HBOT potentially for that patient. So I guess what I'm trying to say is I've also kind of came to a similar conclusion, like on my own, is that there's like different ends of the spectrum of how aggressive you would be implementing this therapy. So, you know, Dawn is obviously the medication that Dr. Seyfried talks about a lot in podcasts. It's very difficult to obtain, if not impossible for some people. It's extremely expensive, and there are known side effects that come along with it because it's such a strong inhibitor of the glutaminase enzyme. So, you know, how could you, hypothetically, structure a program that is like on one end of the spectrum versus the other end of the spectrum? I'll give you an example and that would be like, okay, maybe you use mebendazole, which we know also has an effect on glutaminase, but is not as strong. Maybe like a lower dose mebendazole on this end of the spectrum, maybe higher increasing doses as tolerated, and then maybe adding Don or replacing mebendazole with Don, like on the other end of the spectrum. Like, how do you see that going in?
Mm. Well, there's many moving parts in that question, I feel, right? Once again, I would start with the diagnosis to see what would be the optimal sort of approach, or how much it would be worth it to consider, complementary alternative, adjuvant metabolic interventions. Then I would probably consider the dietary intervention as the first step. Depends also at what point of the diagnosis we are doing this.
Correct.
If it's at a recurrence, maybe we have to go a little bit faster and accelerate the process. If it's like first diagnosed brain tumor, the surgery is being planned, usually, depending on the situation. Maybe there's a couple of weeks where the diet could be already implemented to try to make the surgical outcomes as good as possible, trying to lower the inflammation, or maybe not. If the tumor is diagnosed late with epileptic seizure or something like that, maybe
Correct.
the surgeon just needs to go in and there's no time to do too much, but maybe fasting or some of these things. Now the anesthesiologist would need to know about it, because a fasting patient or a patient on a ketogenic diet has different considerations with the whole anesthesia toolkit. And then you are considering your options. Let's say temozolomide, radiation therapy. There's some molecular studies to see whether temozolomide would be more or less effective. And at this point, I would be considering, probably some repurposed drugs as an add-on to the standard of care. And for a GBM, I would be considering, but I'm talking from like a research perspective. So
Correct.
now
Understood.
this
Hypothetical
is
research perspective.
yeah. I know patients face these decisions, and I know it's difficult because it's not the lack or of expertise. It's more like everything is new, and you don't, like, the patient really doesn't want to deal with it. They would rather someone tell them what to do.
Right.
But there is some learning process. The issue is that the glutamine inhibitors are still research chemicals. Some of them are in clinical trials, such as the Don products, such as the DRP-104, DRP-104. But as you know, there's like no expanded access for them, so they are sort of on their own line. I believe being tested in a subtype of liver cancer. They were also tested in lung cancer. So I would consider the glutamine inhibitor, for example, the DON. Now the problem is the oral bioavailability is not the best. You lose, I would say, up to a third. You only obtain a third of the dose, maybe half of the dose orally, and now your first tissues that are most exposed to it are the intestinal tissues, which we would try to avoid. I think subcutaneous administration would be better, but this also would need to be tested to determine the optimal schedule of something like that. And whether it's the daily application or whether it's a little bit more pulsed, I think that usually depends on the side effects. So, for example, and now each drug has their own side effect profile, so we need to sort of play around with these variables. Mebendazole, for example, to my knowledge, beside like elevated liver enzymes, which should be tracked, doesn't give much issue. Dawn would be sort of limited by mostly the GI side effects. So it's slightly upsetting to the epithelial tissues in the gut. It can also cause nausea, vomiting at high dosages, but not so much at low dosages. And it might be immunosuppressant if it's being used every single day at a high dose, but it's not compared to other chemotherapies. It's not immunosuppressant. Doesn't alter the hemogram that much. So building that, you would need to bring it into this whole body ketogenic metabolic therapy state. I think it would be most beneficial, both the anti-glycolytic inhibitors or DAWN, when the tumor is more or less managed by standard of care, but it's going to come back. So, for brain tumor, you don't see anything on the MRI. You do a PET scan, there's nothing to see, but you know that in 99.9% of cases, it always comes back.
I mean, very common scenario would be, like you mentioned, present to the ER with a seizure. They get a CT, they see midline shift, vasogenic edema, whatever. They go to the OR maybe that night or the next day. They say, we got all of it we could see, right? The next scan you're talking about, nothing on the scan, but we know the course of the disease, right? Is that what you're referring to at that point, basically?
Absolutely. Yeah. So in that case, I think it makes sense to bring anything from all different research perspectives to try to either eliminate those residual tumor cells or try to stabilize them long term. So most people that are sort of self-administering DAWN or other research therapies, or they go to a clinic where they could do this, are doing it with this. I think this is the sort of the best scenario for it. I think DAWN, maybe it's by the way we have talked about it in podcasts. I think we have to be careful. Like this is a chemotherapy, and it's not a miracle drug. We obtain great results in preclinical models, but at the same time, if you have a 5 by 5 centimeter tumor in your brain, I don't think DAWN is sufficient to control that. Now you would have to maybe do another debulking surgery, maybe bring second line chemotherapy. Now there is less tumor cells, and now it would make sense again. But in the context of, it's more like to slow down proliferation. It also kills tumor cells, but you also need to get it into the tissue. Now you have to figure out how to do subcutaneous injections or find a physician willing to do IV. So it has many problems, and as we are talking about this, you can see that there's many considerations for each individual patient. So it's very hard on a podcast to to determine what is optimal for each patient, because now you say, this is a pancreatic cancer case. Well, now everything is different. Now we don't have to worry about the blood-brain barrier, but there is some anatomopathological issues of loss of function of the pancreas. Maybe if you do surgery, if it's not surgically operate, you cannot do surgery. Now this tumor, it's hard to get rid of it only using, metabolic inhibitors. But I think they are more sort of, as I said, we want the dietary intervention as a baseline, as a metabolic priming, then bring these at medium to low dosages. It's quite difficult to use, 2DG or DAWN at like extremely high dosages. I think that the body suffers, because even though ketone bodies are providing energy, glucose is still being used as a fuel, and glutamine is still being used as a fuel.
2DG for me, man. I'll just say it. Everybody who's ever told me they've tried it has got side effects, even if they're in good ketosis. It just seems like they feel like crap. I mean, the literature mentions it. Oh, it's this non-limiting, non-dangerous, feeling of hypoglycemia, but people who are in it, it feels awful. So I get that. I mean, I think it's fair to say that no matter what metabolic inhibitor that someone was interested in or trying for themselves to help themselves for whatever reason, it doesn't make sense to use those outside of the foundation being ketogenic diet first, right? Like it doesn't, I mean, using them on their own may have some effect, but without ketosis, it doesn't seem like it makes as much sense. Is that fair to say?
Yeah, I agree with that statement, especially looking back at the historical trials for Dawn or for
Correct.
2DG or other, lonidabine, Gosipol AT101. Many of these drugs have been tested sort of as a monotherapy on top of standard of care, and they have failed in clinical trials. I think the side effects can be manageable. Here also there's a little bit of disconnect. I know we had a paper much before I came to the lab in 2008, where Jeremy Marsh, a student of Dr. Seifried, he combined ketogenic diet with 2DG, but giving it every day at I think 30, 40 milligrams per kilogram for the mice. I think they get sick in that circumstance. For most people that I've seen using it clinically, either as a press, so like a low dose, maybe 30, 40 milligram per kilogram daily for a couple of weeks, and then an off period, or slightly higher pulses. I think the side effects are known and are manageable, but yeah, I mean, of course, uh, the feeling of hypoglycemia or other side effects can be limiting. Um, Maybe exogenous ketones can help with that to cover the gap. And everything needs to be, we talking a little bit freely about these things, but all
Right.
these things would need to be very, very under medical supervision and very tightly
Correct.
dose
I think
escalated.
anybody doing this outside of medical supervision is probably asking for problems. Even with things that are quote unquote safe, I think it just makes sense to talk with somebody. And of course, the pushback we get, of course, is that, well, no one talks about this stuff. And I empathize with that. But I do think even some kind of integrative doctor who knows a little bit about supplements and ordering some labs is better than nobody. I mean, somebody's got to be watching you with this because you could get yourself into hot water. There's no question.
Yeah. I think it's more the observation than it's more the supervision in terms of blood work, supervision in terms of if anything happens, you have access to emergency care and many of these
Correct.
things, which are also applicable to standard of care.
Correct.
That's why you
Right.
go to a place and they hook you up
Correct.
to the IV and you are there. Whether you are always, the patient might feel safe, but maybe biologically, maybe you are actually not safe, even though you feel, you have 20 nurses around you, but if something actually happens, there's not much they can do. But,
Right.
I think the supervision, I always, I'm very adamant on tracking and on good blood work and good follow-up to any, whatever therapy you might be doing. Now, maybe with the ketogenic diet alone, you don't have to be that strict. I think fasting is, people worry about it, but it's a natural state of humans, and you don't really like. There's not much in the blood work that will change. But of course, if you are completely, your hemogram is suboptimal, or your metabolic panel is suboptimal, everything is suboptimal. If you are entering into a fast, well, maybe there's other things that need to be figured out before you would do that. And then some of the repurposed drugs, as you know, like many repurposed drugs that are sort of anti-glycolytic are more directed to like insulin signaling and to like metformin or SGLT2 inhibitors. They are sort of trying to help you achieve the best glucose ketone index and trying to put chronic metabolic pressure perhaps on the tumor while your known cells are still in a healthy state. Some of the more direct metabolic inhibitors, 2DG, 3-bromopyruvate, hexokinase 2 inhibitor, lonidamine, Gosipol, these would need to be sort of dose escalated and tested individually. Probably I wouldn't combine them at this point. I don't think we know enough to see the best combinations. The same with the glutamine inhibitors. I mean, hopefully some of these will come to the clinic through different means, meaning like they will be approved for some other indication, and now they will be sort of in the collective discussion. This might be difficult because they are being tested once again in sort of monotherapy, that not even looking at their effect of inhibiting metabolism. Like
Correct.
DRP-104 is tested as a potentiator of immunotherapy of checkpoint inhibitors, which I think is fine. I mean, there's some interesting papers published about this. Maybe the effector T cell function works better with like a very mild glutamine inhibition in the body, and it also, of course, puts metabolic stress on the tumor. So I think these two things should be combined, and it's a good combination. But others like CPA39, CPI613, which is an alpha ketoglutarate dehydrogenase inhibitor. It's very hard for me to say, all right, for this type of tumor, you should do this at this dose at this point. I think we are learning more and more. I think they are useful tools within the context of ketogenic metabolic therapy. But yeah, on their own, I also fail to see whether they would be as effective as perhaps people think they would.
Got it. Well, I think dovetailing into that, there was a phase 1 clinical trial that I read that was about GBM, and they were using, of course, standard of care, debulking, temozolomide. I can't remember if they got radiation, but I think it was standard of care. And they added in mebendazole, and it was a dose escalation phase 1 trial. And they went anywhere, they went everywhere for, I think the low dose was like maybe 10 milligrams per kilogram. I think it may have started at 25, 10 or 15, 10 or 25. But then they dose escalated all the way up to 200 milligrams per kilogram, and which is a lot, for a 70-kilogram person. That's like a lot of drug, right? But my point is that it seemed to be safe. Very few people had to exit the trial. I think they did some dose de-escalation for people who had some transaminase elevations, but it actually, and it's one study. I get it, but the average life expectancy, I think, was like 8 months, whereas the people who got mebendazole for more than, I think it was more than a month or maybe more than 2 months, at whatever dose I think they lived 13 months. So it nearly doubled, life expectancy, just adding mebendazole to the standard of care. And I think it's studies like that in particular, or studies that are in that, we're not done yet paper that looked at all the Dawn studies. I think that it seems that maybe some of these glucose inhibitors, like potential, I mean, metformin does have downstream effects at the level of glycolysis and glutaminolysis, it seems. But my point is that those are medications that we give to diabetics every single day, and there doesn't seem to be any. I mean, other than the known side effects of metformin, there's not very many, a lot of life-threatening conditions that happen giving that daily. Or, mebendazole in that study, they were giving it for months on end daily without immune impairment and an improvement in the life expectancy of those particular cohort. So it makes me wonder, from again, research, just a fundamental perspective, do some of these things need to be pulsed at all? What do you think about that? It kind of turns up the press pulse maybe on its head, but I'm just pushing back a little bit about that.
No, I agree. I mean, each drug would have its own repurposed drug, or even a research chemical would have their own sort of schedule that over time we would see that's optimal or not, based on also on the mechanism and preclinical models. I know mebendazole is being tested not only on that trial. There's another pediatric brain tumor trial, and a couple of others that have been already completed. One issue with mebendazole is more the sourcing and the prescription. Like mebendazole, you can get prescribed by any doctor, but it's usually like 100 milligram per pill, per tablet. And to get to some of these higher dosages, because clinically you would use like 100, 200, 300 milligrams per day for a couple of days, and that's it. The problem with mebendazole is, it's an antihelminthic medication, antiparasitic against pinworms, I believe. And it works because it kills the pinworm. It doesn't get absorbed that much into the body. So it has low side effects, it fulfills its function, but it's very, very, very low bioavailability, oral bioavailability. So that's why in many of these trials, when they did the pharmacokinetics, you need, at least 50 milligrams per kilogram based on their data. I would say maybe between 20 and 50 milligrams per kilogram to actually get mebendazole. Now it's flowing in the body. Okay, now we can expect some antitumoral effects.
Right.
If a person takes very little of it. But anecdotally, you see people taking less and they still report.
Yeah, I've seen protocols where people get 100 milligrams per day, which doesn't make any sense to me, but that's what they get, and they may have some effect, So there's something we don't know potentially, or there's some synergy that we're not taking into account, right? But you're right. I mean, as a standalone, you would expect to have to use much higher doses. Like let's just use a 100 kilogram person, low dose, maybe 2,500 milligrams per day, to get to that level, right? Which seems like a lot for a lot of people who are looking at online blogs of how to go about this.
Yeah, well,
Not to minimize them. They're just trying to help themselves.
no. This is more the issue of the clinical aspects of it. Like, we would love to do a clinical trial to test all these things out. And actually, I wrote an IRB proposal for ketogenic diet plus Dawn plus perhaps other things in the background. It's very hard to get a clinical trial when you come in and you say, oh, we're gonna test. Don't worry about it. It's just a couple of interventions. We want to do a very difficult diet that we need 5 nutritionists for, and the patient's gonna do a 7-day fast, and then we're gonna do this little research chemical done, and then 15 different repurposed drugs and hyperbaric oxygen therapy. Don't worry about the safety and all these things, even though we know people are doing it, so we know the safety is there
Right.
when it's reasonably implemented. But it's not only the funding, trying to find funding for something like this, where every single of the repurposed drugs is off patent, the diet is free, and the research chemicals are also off patent, so it's sort of difficult to do. But this sort of, I don't think we'll get the answer on a clinical trial. I think we could get the answer of the clinical efficacy in a clinical
Case
trial.
reports, maybe? Does it have to be like a series of case reports, you think? It's not going to be able to be approved by some IRB.
No. What I mean is, we can get signals of efficacy in case reports. We can get signals of efficacy in clinical trials, small phase 1, phase 2 trials. But we will never figure out how much mebendazole contributed to the overall. If it's 15 interventions, metformin, SGLT2 inhibitor, mebendazole, fenbendazole, doxycycline, a couple of other repurposed drugs, hyperbaric oxygen, IV vitamin C during chemotherapy, and Dawn, or 2EG and Dawn. It's going to be very hard to, like, even the best statistician on the planet might have difficulty phasing that out, and then you might sort of remove some of the components and see if the efficacy holds and all these things. I think what we are trying to figure out is, considering that people in a reasonable manner do use integrative therapies and off-label treatments and repurposed drugs, we want to solidify the dietary ketogenic metabolic therapy and the pharmacological ketogenic metabolic therapy as a baseline of metabolic priming for all of these therapies, together with standard of care. So now you're comparing any outcome you get to standard of care outcomes, which might take 2 years or 5 years or 10 years, depending on the tumor type. So that's why we always focus on GBM or pancreatic cancers, because in 2 years you could already see whether it works or not.
Right.
And then trying to, within the reasonable things that people might do, which are relatively safe and all at low dosages, and if there's any side effects, then we just stop those treatments. We could see therapeutic outcomes and then try to figure out backwards whether all of those components were necessary. I think, for example, for mebendazole and fenbendazole, I know we often say it might have inhibition of glutaminolysis. This is what my colleague Dr. Burnham Mukherjee saw in some of the glutaminase expression in the brain when you're treating the brain with tumor. With mebendazole, there is lower expression of glutaminase. I think many of these repurposed drugs, or many of the supplements, EGCG and others, especially the flavonoids and the triterpenes and all these things, they are like very pleiotropic. So it's very 100%. Hard to say, is the tumor cell dying, therefore it downregulates glucose transport and glutamine transport because 15 different pathways have been impacted by polyphenol or mebendazole, and that's why we see the lower expression of glutaminase. I do not think, I wish mebendazole was a direct glutamine inhibitor. I don't think it is. I think it's not a glutamine analog. Dawn is a glutamine analog. It basically binds covalently to the glutaminase and to many, many other enzymes involved in any enzyme that has glutamine as a cofactor. So purine and pyrimidine synthesis, hexosamine synthesis, amino acid synthesis, NAD balance. So the redox balance even is altered by Dawn. So it's doing many things. Also in the immune system, there has been a couple of interesting papers published where you can see that an immunosuppressed, immunodeficient preclinical model, so a mouse that has no immune system, Dawn works less than a mouse that has an immune system. And most of the work that we do is in mice that are immunocompetent, so they have normal immune system. So I think that's why also we see better results with Dawn rather than testing it in.
To be fair, would it be a fair statement to say that anybody who's immunocompromised does poorly no matter what treatment you give, do you think? Or do you think that that is specific to Dawn because of the glutamine effects on the immune system?
No, I think it would depend on the type of chemotherapy and the diagnosis. Like maybe for an early stage breast cancer where they use, I don't know, cisplatin or something, like they use some chemotherapy that's intended to kill all the tumor cells, and there's very little tumor cells there. The immune suppression is something that you sort of indirect effect of the treatment, but it can have good outcomes because the tumor is not resistant to the treatment.
Right.
For others, like pancreatic cancer or GBM, I think immunosuppression should be avoided if possible. And sometimes it doesn't make sense at all, like the way the standard of care is structured, where you're like doing the chemotherapy and then after you think, oh, maybe we should do some checkpoint inhibitors when everything failed. Maybe the immune system will go and recognize some neoantigens on the tumor after you have like
most people in order to get a checkpoint, right, or to get some kind of immunotherapy have to fail standard of care chemotherapy, correct? A lot
for
of
solid tumors,
for people to get approved or whatever. Yeah, I get that. Yeah, but then you're giving an immunotherapy and you're giving steroids at the same time, and I'm guessing it's just to throttle back a little bit, like from having some kind of hyper-inflammatory reaction, maybe, or something like that. I'm guessing that. Yeah, I got that. Yeah, it is frustrating. I mean, do you think that are there any, I guess, anything on your radar in terms of like strong candidates that could enhance ketogenic metabolic therapy that's not talked about as much? I mean, we talked about 3-PO and 3-bromopyruvate, 2-DG a little bit, metformin. We talked a little bit about, Dawn, mebendazole, but is there anything else out there that you guys are testing, excited about, that's kind of on the horizon?
Well, I would say the anti-glycolysis drugs, even for at least for my standard, I think they are a little bit understudied, even in our lab. We have always focused on the dietary intervention as sort of the main lever to inhibit glycolysis. But the ketogenic diet itself is slightly limited in the amount. It's more to increase the competition for available glucose. And there is also, of course, stromal first pass, cancer metabolism where let's say you have 2 millimolar, 3 millimolar diffusing from the blood of glucose into the tissue. And the tumor is not alone. The tumor, of course, is infiltrated by immune cells and fibroblasts and blood vessels. And all these cells are also competing. If you're fasting, they are also upregulating glucose transporters. They also want the glucose. So it's sort of hard to say how much of the glucose actually gets to the tumor. Often the criticism that we get when we are talking just about the ketogenic diet is that, you can never reduce the glucose in the body to be like 0.5 or something that would be completely like remove the glucose availability from the tumor, which is true. As you know, you can push the glucose quite low with like Drenic did with insulin injections, but I think there's competition for the glucose in the tissue from the normal cells, and it is not only the absolute value of glucose that is available to the tumor that alters the proliferation rate. The bioenergetics of glucose utilization are one thing, but we know from many in vitro experiments, for example, if you lower the glucose from whatever level, let's say 90% relative reduction, quickly or slowly, you will kill many tumor cells, and many tumor cells will now grow much slower because even though they are sort of locked into proliferation, we think through the mitochondrial damage. Other people think it's through the mutations. Doesn't really matter. They still need the biosynthetic and bioenergetic fuels, but they still have some capacity to respond to signals from the environment, to insulin signals, to growth factors, to glucose availability. So they will grow slower if there is less glucose. That doesn't matter if there is still a little bit that keeps them alive.
Right.
So I think many of the direct glycolysis inhibitors we have not tested enough, and the field has not tested enough in the context of ketogenic diet. There has been, for example, one recent paper with 3-bromopyruvate that I've seen. I think it was in thyroid cancer, and they combined ketogenic diet with 3BP. They got some good results in survival of the preclinical model they were using. But we would need to bring this more into the preclinical testing. It would be nice, and I would be very happy to have all the research lab on the planet working on this problem, is trying to figure out what are the best combinations
Right.
to use of different anti-glycolysis inhibitors, PKM2 inhibitors, different glutaminase inhibitors. But the little secret, the little sort of problem in the field is that you would think that if you want to publish a paper in a good journal, the therapeutic effect would be the number one priority of like scientific rigor or novelty, of like, look at my therapy. I have this very difficult model. Everyone tried to treat it. Nobody has been successful. And I have figured out a combination of treatments that works. And you would think this would be very easy to publish, but it's not. It's like the least important thing if you're trying to publish is your therapeutic effect. It's more about, okay, now you have the effect. Okay, let's figure out what gene is upregulated, what pathway is mediating, what molecular marker, how could we stratify the patient if they would actually benefit from this, and all these things are important. I of course I agree with that, but not before you have figured out the optimal treatment.
Right.
Like I think if you spend 10 years, all the cancer metabolism labs on the planet optimizing, drug delivery, different chemical compounds to inhibit these pathways the best way we can, to have complete remission in any tumor that you might imagine. Okay, let's do a deep dive. Let's see why the thyroid cancer responded
Right.
better than the GBM or
Right.
the pancreatic.
So basically,
breast cancer.
mechanism takes precedent over results of eradicating the tumor.
Well, absolutely. I mean, this is
Yeah.
science.
And don't get me
101.
wrong. I like knowing why too. I mean, I think that's why most of us went into medicines. We like to know why, but that's very demoralizing from an outsider's perspective, actually.
Well, it's just we are a research lab. I guess we often talk about other aspects that are outside that, and the translational medicine and the clinical aspects. But ultimately, our goal is to do science and to do research. And we can have our own priorities in the lab, but ultimately we want to publish papers. We have to, and we have to have that as an academic sort of proof of our work. So we can just, with our funding, we can just spend 5 years testing all different compounds when we know it would be very hard to publish the paper at the end. So we still try to do as much as we can, but usually you also have to compare it to your known treatment. So if we are going to do something, it's going to be ketogenic diet with maybe Dawn, and that's how we brought Mebendazole into it. It's like, okay, let's test one more thing. But these things take, it's very easy for me to say, oh, let's do this, let's test that, let's do ivermectin, let's see how it works. But it takes like 6 months to a year to actually collect this data and to analyze the data and to repeat it many times. So
that makes a lot of sense, Tomas. I guess one of the, I don't want to say criticism, because I don't want to come off as critical to the group up there, because I think you guys are badass. But I think one of the things that I would be guilty of saying is that I do think that there's a lot more a patient could do besides keto, Dawn, and maybe plus or minus HBOT or Mebendazole or whatever. Like, I think there's a lot someone could do, I mean, and I think it kind of dovetails into that next paper that we're going to gently talk about. I think that even is limited of what you could do, right? This is adding some more things, vitamin D, zinc, the cancer stem cell connection orthomolecular paper. It did reference you guys in that, although it was very vague about your therapy, about KMT in my opinion, but I just think there's a lot more you could do. But it sounds like it's not so much you guys don't want to tinker with things and check things out and do that. It's just that you have the reality of this is how science at this time works as a way to, make things get published, and you're kind of limited maybe by that. Is that fair to say, or am I putting words in your mouth?
Yeah, well, I think we try to do as much as we can. Sort of indirectly, we would we would hope that we would inspire others. And I know many young people coming into the field, both physicians and researchers, are very interested in what we are saying, and they're also thinking about it. So they sort of go through their when they encounter these issues in their research or in the clinic, they sort of see it firsthand. But it takes time for people to learn, even for researchers. And it took me like many years to hopefully understand how research and science work, at least in the academic sort of sphere. So it would be great to have more labs testing these things and bringing many. We have many ideas. We write them down on a piece of paper, put them on a little board, but we always must do the things that are more of a priority. Many of these things are sort of more theoretical discussions. I think in the clinic, we could test many things, but ultimately the answer will come from the clinic and people doing it. Ideally, it would be through clinical trials or some platform clinical trials where people could be randomized, or not randomized, even just self-selected into different groups where they would get different treatments. I think when we talk about like what else that we could do, I think we covered many things in the BMC paper. I know you have been. I remember one of your videos. You have been disappointed that the hyperbaric oxygen was not prominently.
And I emailed you
featured.
first, though. I emailed you first about it. You told me. You told me.
I hope you enjoyed part two. I know that I really had a great time talking to Tomas, and really felt a camaraderie, and also I know that I learned a lot by talking to him. I had to watch it over a couple times just to pick up what I missed when I was in the interview itself. But if you like videos like this, please like, share, and subscribe. And until next time.